Thank you very much for that nice introduction, and welcome all the faculty and all the delegates who are doing this program. I start from where Dr. Raman Goyal has ended. Dr. Raman Goyal said that more COVID cases or more staff or more paramedical workers are suffering in non-COVID hospitals than in the COVID hospitals. So I'm asked to speak on basic endo-laparoscopy procedures during and post-pandemic, post-COVID pandemic. And then we have already discussed almost all the guidelines and the recommendation which say that we should not be doing this. Luckily or unluckily, I'm in the northeastern part of this country where they were only...
Subhash, yeah. Please go for a slideshow.
All right. No, I was intentionally keeping like that. All right.
Really?
Okay. So in our state, in the Northeast India, is it okay now?
Yeah, yes, fine.
Yeah. India, we had only one case diagnosed for the first 1 month after the lockdown, after 25th of March. So for us, it was very difficult to accept the SAGES, the EAES guidelines, which were released on 29th of March, because we were totally in the green zone till 25th or 24th of April. Even then, but the first thing which was done in our state and in the Northeast was, there are 8 states and 4 of the states are even today COVID-free. The reason was we divided the hospital completely into COVID and non-COVID, and the private patients took up all the government, the private hospital took up all the government patients, and the government hospital took up all the COVID cases. So that's how they were segregated and we were safe. Now, when we do minimal access surgery during COVID-19, the main concern is not the surgical team or the anesthesia team. It's the concern of about 30 to 40 people who come in contact with the patient, starting from admission, from the front office to to the operation theater, the radiology department, and discharge. So when we were doing, there were not many cases. These were the concerns. If we had to do a patient during Corona pandemic, do we do it or not? Most of the guidelines were telling no. So we stuck to that. We did not take up any elective patient. But at the same time, we had to do many evidences. I'll just share some of the evidences what we had to do. We were also concerned about, I think all this has been discussed, safety of paramedical workers. I'll just give practical tips to some of the young surgeons what we did. We wanted to understand COVID test because they were new to us. We wanted to understand virus in the peritoneum. There was only one article from PISA about one particular patient telling concentration of virus in the peritoneum. There was no authentic study. We wanted to understand, do we take informed consent or not regarding COVID if the patient gets COVID infection in the hospital? We wanted to understand how to stratify and prioritize surgery. Then there was a question of smoke evacuation and smoke handling, which I must say, although Dr. David Lomanjo had said that smoke evacuation is a must, but in many Asian countries, sometimes in smaller hospitals, it's not available. And then we had to also work on the newer protocols for disinfection and OT changes in the negative pressure operation theater, which was again a new thing for the world, because world has forgotten the earlier pandemic where the negative pressure operation theaters were strongly recommended. And then the PPEs and masks need to be worked on. There was one simple understanding for all the countries, that was whether it is endoscopy or laparoscopy, all these procedures are aerosol producing procedures and they are risky. And most of the literature which appeared during this period authenticated this statement. And thus it was decided that we will only be doing the emergency procedures. Now, the concern was, if we defer OPD and elective, how do we handle our OPD patients, and how do we save the urgent and emergency cases, and what precautions we take, and how do we limit our resources in case, because we have seen that in the West that they are exhausted with their resources, and particularly in Italy we have seen that And but then we had cases like this. This patient had a strangulated hernia whom I had to operate during this pandemic. Similarly, there were many patients we need to be operated. The first thing we did, we prioritized our appointments and we started teleconsultations. So all those patients who wanted to come to us for review of a checkup were all cancelled or postponed for the time being. There were only emergency patients taken up for consultation. The government of India came with a guideline that teleconsultation is now allowed, which was earlier there was some ban on that. And now we could evaluate our patient, we could have a video chat, we could have a teleconsultation. At the same time, we could discuss with our colleagues in remote places where the patient could consult us. The first thing, the next thing which we did was the OPD safety of a patient. You can see this is the garage of my ambulance, which was converted into a triage area where the attendant was taken a history for the patient could enter, and we were very careful. Even the lady who is there, if this patient is a COVID positive patient or the attendant COVID positive, she might become positive. So before this patient, emergency patient was allowed to enter the emergency department, all precautions were taken. Even this, you can see small things which we did. Small plant pods were kept so that the patient who may not understand were kept away from the front office. And this was one innovation where I can also see my patient next to me sitting my assistant with a small teledoc. So that's how we did a social distancing. We also, I'm in this attire, even now I'm in this attire. We completely changed our attire the moment we reached the hospital. Because we are operating also in all emergency patients. So we switch over to these surgical scrubs, and on top of that, we could put on an HIV gown. Gown is very good off. We are always on goggles because the patient can give you a droplet infection in outdoor, not necessarily only in the operation theaters. And with full covered shoes and a cap almost all throughout the day when you're working in the hospital. We also did one thing. I along with my surgical team members, because it was clear that the hospital may have 30-40 COVID patients who will ventilate. We already have shortage of ICU doctors who might be taken up by the government hospitals. So we learned the basics of ventilation and this. And then we now, I just move on. I think Professor Indrani has already covered the anesthesia part, so I'm not going to do this. But then we fully agree. The basic principle was, while at the time of induction there should be only 2 or 3 people, apart from the anesthesiologist, there were 2 or 3 people. And I think this part has been very nicely covered by this thing. The next thing was informed consent. I do not know the validity of the informed consent as of now, but it will definitely give safety to our somewhere, somehow, because there were 3 main concerns. Patient had to understand that he has come during a corona pandemic. That part will need to be included. He may infect himself. He also needs to understand, which was a part of the consent, that if operated, he has a high risk of mortality and morbidity, as is evident in whatever is available in the present literature. And also, he has to understand there will be additional cost involved in the surgery because of the extra OR time, and also because of the extra PPE and the mask which he'll be purchasing for the team. Now, how did we organize the emergency surgery? The COVID test has not been made mandatory by the government, the Ministry of Health of India, and also the ICMR guideline says, because of the shortage of the COVID test, the ministry is insisting that
probably we are having some internet connection problem. Yeah.
Only done in symptomatic patient. The ministry has never insisted in any other investigation so far, whether it is any other retroviral study, a HIV study. But am I audible now?
Yeah. Now
am I audible now?
Yeah, it is little better now. Yeah.
Yes.
It was.
Okay, I'll come nearer because I think because of the rains here, the internet is slightly unstable.
Yeah, I understand that. Huh.
Okay. So
So you can sum up in
okay,
2 minutes. Okay. Yeah.
Right. 2 minutes. Fine. So the pre-operative COVID test would soon become a mandatory. We would like to go for a rapid test or IgG, IgM rather than going for RT-PCR, because that takes time in emergency situations. And so that's how we prioritize our study, our surgeries. The main factor was, can the patient wait? Is there any alternative? Can we? So while postponing the surgery, we will always look for any alternative methods of treatment in that particular patient. The OT guidelines were very important for us. So we created an artificially a negative pressure operation theater, and in between the time between the cases was kept at least 1 hour or minimum of 45 minutes for total desanitization. The donning and offing area were earmarked. Laminar flow was kept on when the OT was totally locked, but then at the time of induction it was switched off. We planned the surgical strategy for smoke evacuation, as has already been discussed. And that's how the team for endoscopy OT worked. They were all in PPE, as less number of people, one CM technician, one anesthetist, one helper nurse, and one instrument nurse. Staff safety, I think we have all covered. Operative director, we have covered about the OT ventilation. We have covered this part. The OT temperature was kept between 21 to 24 degree, and the humidity was kept at low. And those are the for those who are very new to HEPA filters and the ventilation. And these are the filters for which normally there are 12 exchanges per hour. We wanted higher exchanges in case you're using the exhaust inside a negative pressure inside the OT. I think time won't permit me to speak on that much. Those are the vents where we have fitted now the strong exhaust and the HEPA filters from where the exhaust air can be exhaust, and the doors are hermetically closed there. That was the concept of negative air pressure in the OT. And I think we have spoken about smoke evacuators. We can see this is from my friend Arun, who had given that. We had to do some patients who came to us with obstructive uropathy. We had to do many patients with septic cholangitis. We had to, I think we'll be discussing this about the face mask and shield in the question answer session. We had to also take up the advantage of robotic surgery, which is said to be presently, and I also personally feel it is safe when you can operate from a distance, and your team also, after the installation is done with bedside units, they can be away from the patient, and they are completely safer. I think if time is not permitting, I can just conclude here. Ladies and gentlemen, it's time. It's almost 2 months when our patients, our routine patients, are suffering. That's why IGS has come up with guidelines for how to restructure and resume our surgical practice. How to, there are some patients, those who must be given benefit of surgery, particularly patients having early cancer, resectable cancer. All these patients are waiting. So I think it's time that, as Dr. Raman Goyal said, we have to plan our protocols and how to plan the surgery. Pre-operative testing is mandatory in our cases. In all the cases, the next couple of months, healthcare worker safety is going to be mandatory. Patients' consent form is going to be mandatory. Prior surgery must be done, and we have to resume surgical practice with proper protocols, I think. And for the timing till the COVID test is available, I think we should take all patients as positive, whether I'm working in a COVID or non-COVID hospital, and proceed and go ahead. I think there might have been some repetitions because Dr. David Levanter and Dr. Raman Goyal has already covered most of the guidelines. Thank you very much. Let's learn the lessons from what we have seen and what we have read, and let's move on. We are fighting an invisible enemy, the nature of which is not known to us. Thank you.
Thank you. Thank you, Subhash. Thank you for your nice presentation. And